Hello, today the topic is the diagnosis of boreliosis, so very important topic. And in front of me, there is an expert on that field, Professor Leoną Gilbert from Finland. Thank you, Leona, that you have found time to answer some questions and talk about important topic for many patients and many doctors.
Well, thank you for having me. This is really great, important topic for everybody, as you said. Yes.
Yeah, so I would like to start with a very basic question, because all around the world, there is only one method which is really recognized to make a diagnostic or to make to diagnose borreliosis. It is called two-titered testing for Lyme disease. And maybe you could maybe give us information what this method is really about, because many patients, they don't understand. And then I would like to talk about history, about some limitation of this method, but maybe could you please explain that method?
Yeah, so the two-tier system is based on kind of two tests that is needed in order to get a final Lyme disease diagnosis. But it starts with the symptoms. So the practitioner will ask the patient, how long have you had your symptoms? Okay. And if it's less than 30 days, they will say, okay, I will order the first tier testing. The first tier testing is a screening test, and it's immunofluorescent assay or it's an enzyme linked immunosorbent assay. So it's the IFA or the ELISA assay. And that assay there is, like I said, it's the screening assay. And if that is positive or equivocal, meaning borderline, then the practitioner will order the second tier. And traditionally, the second tier is a Western blot, okay? And it's a different parameter than the ELISA or IFA, but meaning that they use hopefully different bacterial species and maybe purified proteins that enhances the specificity in the second stage. And this two-tier system, you need those to be positive, both of them, in order to get a positive Lyme disease diagnosis. And unfortunately, it is accepted. It's the kind of like the gold standard of diagnosing Lyme disease all over the world, unfortunately, because guidelines still dictate this two-tier algorithm to be utilized to diagnose Lyme disease. But unfortunately, there is really many pitfalls in this. And I do understand why initially the two-tier system was used, because in the 80s, and this is a little bit about the history, but in the 1980s, the first test, okay, had a lot of false positives because of cross-reactivity. And because of the false positives, clinicians back then wanted to make sure that they could reduce the false positives by having the second test that's more specific, and hence why we have the Western blot. But those tests and that algorithm is based on only the Borrelia burgdorferi sensostricto species, okay, only one Borrelia species, and on a very small set of patients, okay, and that's really why you hear all this statistics saying that, the two-tier system fails in 60% of the cases. And it is true, but we have to remember that the two-tier algorithm is using tests that are based on serology. So the patient's antibody response, okay? It is not a direct test like in PCR, okay? It is a serology, an indirect test. And with an indirect test that utilizes serology, of course, there's going to be pitfalls, okay? And that is that our own biology, our own immune system requires a few weeks to build up those antibodies that we could see in these tests. And that is a pitfall for all serological tests. We just have to wait the 2 to 4 weeks, okay? And more in some cases in individuals that especially in individuals that have a compromised immune system, some of those patients don't even build up an antibody response against pathogens. So there are pitfalls, and these pitfalls, like I said, are across all serology tests. But we have to keep that in mind, because that tells us that let's use the test appropriately. Let's not use it within that window of 2 to 4 weeks. And in a lot of the cases, clinicians are ordering it immediately, after a tick bite, and have to kind of educate ourselves in saying that no, let's wait. We have to wait the 4 weeks, unfortunately. So that's really a pitfall with serology, but with the two-tier system, because it was based on, you know, full lysates, okay, like full bacteria, Borrelia bacteria, lysates, that they just broke up the bacteria and put it in and utilized it. There was a lot of this cross-reactivity, as I mentioned earlier. But nowadays, okay, nowadays, ELISAs are manufactured to prevent a lot of cross-reactivity based on purified recombinant protein, based on peptides, okay? So the robustness of these ELISAs from 1980s or the early 1990s have incredibly increased to being more robust and accurate and sensitive and specific nowadays, because we have these newer technologies. So the narrative that's people say that, well, ELISAs are failing in 50% of the cases, that's not true anymore, because we have really good manufacturing techniques in order to prevent cross-reactivity, prevent false positives, prevent false negatives. And that's the thing that I'm trying to encourage in correcting the narrative, that we have really good ELISAs. Okay. But I just want to mention one other point here. The two-tier system that was developed with the ELISA in the first tier and the Western blot in the second, well, that has now been approved. I think in 2017, CDC has actually endorsed 2 ELISAs. So this modified two-tier system, or sorry, it was in 2019. Yeah. And now the modified ELISA or modified two-tier system relies on the first tier being an ELISA for screening, and a second tier being more specific, and it's still an ELISA. So you can use now 2 ELISAs, which is nice.
I have a question. As I understand the idea, you said that the situation has changed from the 80s now. You know, it's 40 years. So in the history of medicine, it's like prehistory of, you know, laboratory tests, actually. But as I understand, the first step should be, let's say, oversensitive. And the second step should be very specific, to be sure that there is no mistake. Like when we use this two-type method at the moment, is the first step oversensitive and the second step very specific? How is it at the moment?
Well, it depends. Of course, it depends on which ELISA you use, but I would encourage that we have only one step. Okay. With not an oversensitive, you know, first tier, but we have a very accurate one step, okay, that is like 95% specific and 98% sensitive. I would encourage that, okay, instead of an oversensitive ELISA, okay. And I know that we're not going to replace the two-tier system immediately, but there is a movement towards better diagnostics, okay? And that's the whole point. We just have to utilize those better diagnostics and realize that the sensitivity and specificity has moved from 60% all the way to 95, 98% in these test kits. And that's what we should be looking at in the performance of these ELISAs. Because if you have a 98% sensitive first tier and a second tier, that's excellent. Why do we need the second tier? But why do we need the second tier? You know?
So you asked the question why. So I asked you the question more about history. When you mentioned, for me, it's a little funny that you mentioned the test, the idea was from the 80s. So, you know, nobody is driving the car produced in 80s. Nobody's watching television produced in 80s. But we are using something more important that, you know, life, health depend on the test. So I know also from the history that HIV, you know, infection, it started maybe in not perfect way to be diagnosed in like 80s together, like with boreliosis. And now we have very good tests for HIV and still quite poor tests for boreliosis. So the question is why?
Why?
We are using this very old, out of date test at the moment.
Yeah, because regulatory agencies are still endorsing the two-tier system. Okay, so FDA, CDC, and because of their endorsements, guidelines, of course, are well, CDC endorses, you know, the guidelines that are set out by IDSA. Okay, And because of these regulatory endorsements and society endorsements, then insurance companies are going to follow suit, and they're going to have policies only to support those tests that are endorsed by CDC. So this perpetuates the whole kind of use of old kind of algorithms used, and that's the whole point, that we need to change it at the level of the CDC and the FDA, so that the health insurances and health agencies follow suit and changes their policies. Okay, and this whole old concept of the second stage being more specific, it's such an outdated concept, but it's still within this regulatory endorsements mindset, and that's the thing that we need to change. And also, in order to change like regulatory FDA endorsement, okay, of the two-tier algorithm, it really means an infrastructure change as well. So it's not just a mindset, it's an infrastructure change. And then the change has to follow suit through the clinical laboratories, the associations, and so forth. And we know how resistant changes, okay, but it all starts with this, I think, with this regulatory endorsements. Once we have that, then we can start changing. And incidentally, by the way, the two-tier system was initially used for epidemiological, okay, data, not clinical data. But we're still using it as a surveillance method for clinical data, and we should not be doing that. Like, it's such a pitfall.
So the first papers was more like for politicians, I would say, or for some other people that would like to have more statistical data, not for the doctors and not for the patients.
Exactly. Yeah. But now, but of course, the gentleman and people got associated in developing these two-tier system, and it's incidentally the people that actually developed that algorithm, they also unfortunately hold patents on those test kits, and unfortunately, and unfortunately have published in the area as well during that time, and standard that this is the gold standard, the two-tier algorithm, and the rest of the world follows suit, thinking that this is the way to do it. But of course, there's little differences in the diagnostic criteria in some countries. Like Health Canada demands that the person has to be bitten in a hot spot, and they have outlined a hot spot meaning where ticks are. So only in those areas, if you've been bitten by a tick, will you be able to get a Lyme diagnosis. So if you are like 10 kilometers away from that hotspot, and if you've been bitten by a tick, you will never get a Lyme disease diagnosis.
Okay.
Yeah.
It's funny that, American idea is now used everywhere. I was really laughing when I realized that in Russia, they were following the same, idea from the United States. So they could be in war, but talking about the test, they do the same.
Exactly. And, in Finland too, they do the same. You have to be, from an endemic area, and it's interesting, even in this country, like they don't test for all major, the 3 major strains of Borrelia. Okay, they have their own very specific one in one city, and then another specific strain in the other city. And it's like, okay, why aren't you testing for all 3 strains? Because these patients are responding to all 3 of these strains. So, and they're seen, those strains are seen here. So it's interesting, this mentality of why they think that this two-tier system is still working. Of course, the whole reasoning also is to really prevent this, false positives, okay? And, and maybe overuse of antibiotics. They could use that as an argument, and that's why we get into actually, the question of, what is the definition of, Lyme disease? Having a very strict definition of Lyme disease, prevents false positives, and too many overdiagnosing, okay, but also prevents the overuse of antibiotics. But then I think about those people that have acne, they're put on tetracycline for years and years and years, and this is kind of funny. And also a prophylactic response to malaria here in Finland was taking 11 months of doxycycline. So
Yeah, yeah.
so the mentality in these arguments are interesting for me to understand sometimes.
Yeah,
Yeah.
I believe that the decision about use of medication like antibiotics is something between doctor and the patient, not somebody else, actually, you know.
Exactly, because it's the doctor that knows the whole outlook of the individual, of the patient, okay?
Yeah, yeah.
Okay, and we don't fit into black and white guidelines. People are
Yeah.
different, so it's interesting.
Okay, so before I interrupt you, you
Yeah.
started to talk about pitfalls of this two-tiered methodology. Are there any other pitfalls, limitations, or what does it really mean for the patient that this method is still in use?
Yeah, well, I hear constantly the wrong narrative that if a IgM is positive, it's a false positive. It's a false positive. It's a false like IgM is disregarded. Okay. And it's so misleading to disregard the IgM antibody because we know, okay, Borrelia is yes, it's a low abundance bacteria. It's a low abundance. Okay,
Yeah,
you won't find a lot of it, but it has a big punch. Okay,
yes.
Yeah. So direct detection of Borrelia doesn't work very well. So we have to use serology. And when IgM, okay, is made, traditionally it's for acute cases,
Yeah,
okay, and then IgG for dissemination in late cases. However, there is a subset of articles that have been published, and more we are seeing that in those individuals that have a dysfunctional immune system or dysregulated immune system, they may have an IgM signature that
yeah,
lasts a long time. That
yeah,
lasts, and there could be those patients that have an IgG signature, okay, antibody signature against Borrelia that lasts a long time. And we are seeing also another subset of patients that have IgM and IgG together, like,
yeah.
and that lasts a long time. But we have to realize and look at their symptoms. They're not asymptomatic people.
Yes,
These are
yes, yes.
people that are chronically ill. These are
Yeah,
people that have been ill a long time and their immune system is dysregulated. Okay.
yeah.
And that's the point, that we should not be disregarding IgM, and because these test kits again are manufactured robustly to
Hmm.
prevent false positives and false negatives, okay, and to prevent cross reactivity. So to empower the patients, they should question if their IgM signature is disregarded. Say, no, look at this. This is demonstrating that the immune system is at a dysregulation. Okay,
Hmm.
and this means something. Means
Yeah,
something.
yeah.
And also the two-tier system disregards any post-treatment Lyme disease or chronic Lyme disease patients.
Uh-huh.
It does not consider it at all, at
Hmm.
all. And one of the major pitfalls I find just astonishing is that it's a qualitative, okay, algorithm. Qualitative, yes, no, borderline. That's it. Why aren't we actually getting quantitative data from the ELISAs? Okay,
Uh-huh.
we can get that data. Okay,
Uh,
and if we get quantitative data, we can see if antibodies are going up, antibodies are going down, and in what day or what week or what treatment protocol prevents these from going up or down, or and so forth. So in a sense, we can utilize quantitative data in order to actually look at treatment success or failure. And
hmm.
and and I don't understand why we don't have that data. It's so basic. It's like one of the
Hmm.
basic skills ELISAs can provide, okay, us
Hmm.
and to clinicians and to, patients. So we should be looking at the qualitative, yes, no, borderline, but also quantitative data. Yeah.
Okay, okay. So you also mentioned that there is already this move towards making some change. And I wonder what's going on in Europe about that. I know that a few years ago we had this United Europe resolution, which states that the tests are not perfect. There's really huge need to do something about diagnosis. Is there any, and there are any changes about this
Well,
diagnostic tool?
well, I actually interesting about, let's go just digress a little bit. You said the EU resolution. That was a resolution for neuroborreliosis.
Yeah.
Yeah, so neuroborreliosis, and there are very clear guidelines on how to diagnose neuroborreliosis, and it is not debated as much as Lyme disease. Okay.
Okay.
Okay. And so it's very clear, objective symptoms and test results, and also based on ELISA. So it's very clear in Europe what neuroborreliosis is, but it's not clear for Lyme disease.
Okay.
All the other manifestations, okay, of Lyme disease, like arthritis, like skin, okay, presentation. Yeah. So, and it's reportable. That resolution demands that countries report neuroborreliosis. So it is forgetting all the other patients.
So you want to say that with borreliosis is even poor, like there's no talk about that at all?
Like there's no demand of reporting for Lyme disease outside neuroborreliosis. Okay, so as soon as you can find antibodies in your central spinal fluid, as soon as you have Bell's palsy, as soon as neurological symptoms, then it's a clear indication it's neuroborreliosis. Okay, clear guidelines on how to diagnose it. But for the rest of the manifestations of Lyme disease, like Lyme arthritis, Lyme carditis, acrodermatitis, all of those manifestations, there's not clear guidelines, and that's henceforth why this two-tier system. And actually, the two-tier algorithm doesn't even consider neuroborreliosis. Okay, they should look at the European diagnosis criteria for neuroborreliosis and adopt it, because it's very straightforward. It's not contentious. It's not debatable as much as the other manifestations of Lyme disease. But that's the whole problem with our thinking. We think that there's only an American strain and it's only in US. Okay, and then we think that there's only European strains and the European strains are here, but they're everywhere. Neuroborreliosis is in North America, okay? and Lyme arthritis is absolutely here in Europe. So that's the problem with the two-tier guidelines, okay? It does not consider all these other presentations of Lyme disease.
So we know what's the situation, and it's a problem. I believe that for many patients, it means that they do not have the official diagnosis, they do not have positive tests, but they have symptoms. Could you make a comment about that?
And that's the thing, because the symptoms, yes, they overlap with a lot of other pathogens, like infectious diseases, and also autoimmune diseases, okay, and other diseases like chronic fatigue syndrome and so forth. And the symptoms, though, can tell a lot about actually all these other co-infections as well. And that's a major thing that the two-tier system does not consider, is the co-infections, because very rarely are chronic patients seen only suffering from Borrelia alone. Very rarely. 85% of these chronic Lyme disease patients or post-treatment Lyme disease syndrome patients suffer from multiple microbes, like Bartonella babesia. And it could, and also if they're so sick for a long time, again, their immune system is at a dysregulation, so they're more susceptible to these opportunist infections, okay, that come out, like mycoplasma infection, like Epstein-Barr virus, like, so forth and so forth. So we're not even considering the co-infections, and we need to be doing, and also these opportunist infections. So I really think that we have to look holistically at the patients, okay? And look at the symptoms, how diverse the symptoms are, how long they have been sick, okay? And look at the fitness of the immune system, because that all participates into making decisions, informed decisions about what type of testing. And the testing should be really robust test kits for, yes, Borrelia, with many different species of Borrelia, the chronic, and also the chronic form of Borrelia as well, okay? And then the co-infections and possibly opportunist infections, because that will give then the overall picture of, what's going on in the immune system, as well as the infectious biomarkers that could be seen.
Okay, so maybe it's good time for you to introduce your work, because we know what's the problem. You are working on the field of finding a solution, and I want to tell more about the TickPlex test, like on a blog, new serological test, could you, because maybe it's in use for a few years, but
Yeah.
I believe that many patients, many doctors, they are not familiar at all with the test. So
Okay.
could you tell us more about what's new about the test, about
Yeah.
methodology?
Yeah.
Introduce.
Okay, so I'll just give you a short little history. This TickPlex is based off of my research group at the university here in Uvascula. And we decided to actually do better for the patients and include the 3 major species of Borrelia bodorferi, okay, B31,
Yeah.
or sensu stricto, Borrelia garini, and Borrelia afzeli. And also our research from the university with my PhD students and master's students showed that actually chronic patients have an antibody response against the persistent forms of Borrelia. And it's very unique. It's very unique, okay? And we even demonstrated in our research that there were certain peptides that are very unique that elicits an immune response that's very signature of a chronic Lyme disease patient or a post-treatment Lyme disease. So the persistent form against these 3 major strains, the spirochete form, the parent form of those strains, was developed into an ELISA-based platform, okay? And we used ELISA because we didn't want to change what the clinical laboratories had, okay? We wanted it to be high throughput, but we wanted it to be very robust and very specific. So very sensitive and very specific. So with 95% sensitivity and 98 specificity, okay? And with minimum less than 2% of cross-reactivity. Okay, and less than 5% of false positives and false negative results. So we really wanted to develop this TickPlex basic, only focusing on Lyme disease, but using the 3 major strains. Okay, and so we developed this, and we did a proof of concept study, and in it we really saw that 85% of these chronic patients had then multiple microbial infections. Okay, so that got us to analyze an additional basically 40 different pathogens, and we statistically analyze which ones are more prevalent. And we put that into a new diagnostic called TickPlex Plus that has co-infections and opportunist infections. So it has Babesia, Bartonella, Ehrlichia, Rickettsia, and it also has Mycoplasma, B19, Coxsackie virus, and Epstein-Barr virus. So basically, TickPlex Plus has the Lyme disease, okay, with its chronic form, okay, as well as co-infections, okay, coming from the tick, and opportunist infections. And we had this expanded panel because those opportunist infections, 85% of the general population will have seen these pathogens before, so we can see if their immune fitness is at a good state that could elicit antibodies. Okay, because if, like I said, 85% adults have seen these, so they'll have some type of basal antibodies there, and we developed the kits that we can recognize the basal level of antibodies, but we also could see if they are truly infected or if those viruses are reactivated, okay? And it tells us about, the fitness of the immune system. So basic and plus, yes, Lyme disease plus co-infections and then opportunist infections. And with the plus, we really get an understanding of how fit the immune system is. And we are doing, we screen for IgG and IgM, okay, separately, but on the same test. Okay, for both basic and plus, so we can see what stage you're in: acute, dissemination, late stage, and chronic stage.
Wow.
And yeah, because we have the chronic forms there. So it's a really good overall tool, first and only the tier that's needed to get a proper diagnosis of Lyme disease, but also then hint on these co-infections as well, and then opportunist infections.
Okay, it's hard for me not to be a little ironic, because some doctors say that chronic Lyme does not exist, and you just said that you have a test for non-existing disease.
No, I know. But if you look, and it's not just us showing that chronic Lyme disease exists. We know that the other scientists have demonstrated this, but we are the only test that actually is developed in the world that's actually approved by health authorities to be utilized to diagnose chronic Lyme disease. And
yeah, I want to really emphasize that.
yeah,
We have a test for chronic Lyme disease.
we do.
Approved.
Yes, we have the test for chronic Lyme disease.
Capitals letters, yeah.
Exactly, exactly. And yes, it has gotten resistance. Of course it has, because as you pointed out, you know, we have a lot of clinicians not believing in chronic Lyme.
The same. They say that there is no resistant form. Yeah, we have the test for resistant forms of Borrelia.
Yes, yes, we do. Exactly, exactly.
Okay.
But you know,
yeah. Tell me about sensitivity and specificity, because that's the question of many doctors, patients.
Yeah, in the understanding of it, right? Okay.
Yeah.
So sensitivity, as we know, is the proportion of people with the disease. And if the test can actually see the people with the disease, so they will have a positive diagnostic test. But specificity is the proportion of the people without the disease. So they'll have a negative, okay? And these earlier test kits, okay, and the assessments, you know, the assessments from the first 10 to 15 years of ELISAs that have been, you know, used for Lyme disease diagnosis, the sensitivity has ranged anywhere from like 30 to, let's say, 75%, okay? And then the specificity, okay, has been quite good because of the Western blots, okay, all the way up to, let's say, 98. But again, it's based on very small subset of patients. So you really have to think about how many patients were tested to determine the sensitivity and the specificity, okay? And as an example, the new IgG immunoblot, if you actually read the instructions for use, okay, that has been cleared by FDA, you can see the overall sensitivity is only 75%.
Yeah.
75%. Like, is that good enough for us? No, I don't think so. I think 95% sensitive is a lot better than 75. Yeah, so our test is 95% sensitive and 98 with specificity, okay? And this is based on 1,500 patients, okay? And we're increasing and reevaluating every year those parameters to make sure that our test kit is really robust in the field. And that's the thing, like, it's a legal demand of ours here in Europe that we're always trying to improve the robustness of the test kits, okay? And we have to demonstrate this, like in our instructions for use is a legal document that this test kit has, and anybody can ask for it, and we have to provide it, okay? And it has the clinical parameters, okay, of sensitivity, specificity, and robustness and accuracy and so forth, documented in this instructions for use. So I really encourage patients and clinicians to demand this instructions for use on the test kits that are being used, okay, on their patients, because in it will have the performance parameters of these test kits. So we can stop this wrong narrative that, oh, the ELISAs are missing 80% or 60% of the patients. That's not true. It is not true at all. We need to correct that narrative and empower the patients really with knowledge, and the clinicians. So instructions for use.
There's a huge need for knowledge, because there are a lot of rumors, a lot of emotion, but we really need to have data and knowledge.
Yeah, and the data has to be provided. It's not just a summary of data. You have to demonstrate the data. You have to provide the data, because you know, I would think that we practice medicine based on evidence-based medicine. Evidence-based medicine. Provide me the evidence, please. And I'm all about trying to, you know, encourage this narrative. Demand the evidence. Okay, so if the manufacturer is saying that the Elite Spot is, you know, the best test kit, well, show me the evidence, okay? Or if TickPlex is the best test kit, okay, show me the evidence. I will give you the evidence. Or if TickPlex, you know, is the test for chronic Lyme disease, I will show you the evidence of it.
Okay, so let's make it clear, because, you know, I'm not expert on the laboratory tests. Does it mean that many tests which are available, they are, let's say, not evidence-based, manufactured without that, you know, knowledge?
Well, in Europe, we have the European Union that regulates all diagnostic test kits that can be used for the diagnosis or the aid in diagnosing of any kind of disease. Within it, Okay, if it is CE-IVD marked, that means the European Commission has approved it. It is actually validated analytically and clinically validated. Okay, it is. So there has to be data if it is CE-IVD marked. If it is, then demand it because it has been validated. It has been clinically, analytically validated. Okay, but there are those test kits, okay, that are developed within house. They're called in-house here in Europe, in-house test kits, in-house. Those in-house test kits do not have the same strict demand as CE-IVD marked products here in Europe, okay? They usually need to demonstrate safety and efficacy, But if you are a customer and if you are paying for that test, in-house test, I would demand the evidence of analytical validation and clinical validation. I would demand it. Okay. And let's hope that they can provide it. Okay. If they cannot provide it, then I would move on and not use that test because you don't know the performance of it. Okay. And if the manufacturer doesn't want to surrender this information, this evidence, then I would really caution using that, you know, that test. On the other side of the world, FDA obviously gets approved or cleared, but they also have, on the other side of the world, laboratory developed tests. Those are equivalent as our in-house tests. Okay. So FDA cleared and approved tests have that legal document, the instructions for use. So they have to show the analytical validation and the clinical validation. And it's a legal document, so you have every right to see it. Okay. But the in-house, there's the efficacy, okay, safety, efficacy. There is maybe some validation if it's a CLIA lab that has the LDT, which they should minimum be a CLIA lab. It's just a standard accreditation standard for the laboratory. In those CLIA labs with a laboratory developed test, they are not legally obliged to provide this analytical validation or clinical validation. Okay. But I would still demand it. And if they can't demand it, or if they don't surrender that information, then I would be very cautious on it. Okay. Yeah. And that's the thing. That's how we can empower ourselves as consumers, as patients, you know, and also as clinicians, okay, and practitioners that, you know, demand it. If you say you have the best test kit, then prove it. Give me the evidence for it, because we have a lot of wrong narrative right now saying that, oh, the leases are wrong, there's no, or my test is more specific than yours. Well, provide me the evidence. Yes. Please. Yeah.
Because of TickPlex Basic and Plus, the new test, we just need to say it's not in-house test.
No.
It's really good test. And, you know, I'm using that for a couple of years and I like it. It's really good tool for my patient, but, you know, it's not so known. But for the purpose of this interview, I'm sorry, I need to be kind of devil's advocate. So what are the limitations? I know you already mentioned some generally serological test limitation, but tell us more if there are any problems with that test, any limitations we need to know about TickPlex.
Yeah, I think for TickPlex, because we have the three major strains of Borrelia, okay, like we have Apsilis and Senso Stricto, we have those three main strains. So it's limited in the strains, okay? And that's I think the key point with all serology too, is you have to look at the very specific strains, okay? But we made that conscious decision that we took the three most prominent ones because, again, we analyzed 1,500 patients. We statistically deduced that these are the strains. So that's a limitation with TickPlex. Absolutely it is. Absolutely. But I would argue, being a devil's advocate too, do we need to over-test for these different strains? Okay. Do we really? Because there are same peptides on each of these Borrelia sensolata group, okay, the same peptides. And that's the point, that we are always surveying these, you know, new peptides and doing new performance, you know, analysis to make sure that we have the best peptides and the best proteins in our test kit. But anyways, that's the limitation. Also, we have two species of rickettsia. There are a handful of rickettsia. So if we're moving our test kit to, let's say, Australia, we may not have the Australian rickettsia, okay? Or if we're moving, well, our test kit is actually COFEPRIS approved in Mexico, okay? So the health authority approved in Mexico. So it's Europe and Mexico at the moment that's approved. We're en route to other countries in North America and other places. But the point is that there are interesting rickettsia species in Mexico. So our test kit can be limited in that way. And therefore we may miss some rickettsia. But again, if we have a peptide that is very useful analytically and clinically that covers a broad spectrum of rickettsia, then of course we're going to jump on that. So species, limitation of species, because there's only a limited amount of space on this test kit anyways, okay? Okay, also a limitation, if I can say, we're providing 15 different pathogens, 2 antibodies, so that's 30 tests, okay, wait, and we're providing yes, no, borderline results on all of those antibodies, all of those, and quantitative.
Yeah.
Do you know how many test results that a practitioner and a patient can get? Like, this is overwhelming, okay? It can be overwhelming. It can be. So there is a lot of education and training that is needed, okay? Not only for the clinical laboratory itself, but also for the consumer and also for the practitioner, okay? So this is what I wanted to say, that it is a multiplexed test kit. You're getting a lot of parameters, so 60 different parameters, okay? And you have to make sense of all of it, okay? So we do have an interpretation tool that we have worked on with clinicians, okay? So what does this mean and that mean and this and this and this and this? Like, so we have that interpretation tool. It is backed by science, okay? It is backed by research, our research and others' research, but we do provide this, but it could still be overwhelming. Like we had a discussion that there could be a persistent IgM signature, antibody signature. Well, we're seeing that with other microbes as well. Okay, we really are. So chronic patients can either be seronegative, where they don't have an antibody response, okay, and that's serology tests in general, or they could be hypersensitive and have too much of an antibody response, okay? So the point is we can recognize those now, okay? And those subset of patients that have an oversensitive immune system, okay, or at a dysregulation, or a seronegativity that they're not even producing. So the limitation really is a profound amount of information, okay? So the readouts, we work with the clinical laboratories that are using our test kit to provide a very user-friendly readout for the clinician and for the patient. So hopefully it's not too complex for them. And then we have this interpretation tool. But it is a limitation. Too much information can be confusing. Because I constantly get told, oh, it's a false positive IgM. No, it's not. It really isn't if you look into it. It's interesting, these patients. Yeah.
You know, as I said, I'm using the test for a couple of years. I mean, here in St. Luke Medical Center in Gdańsk, we are using that to diagnose our patient, but unfortunately it's not so popular, maybe in some other places. Could you tell us maybe about future of the test? Do you I'm talking about if you want to develop the test, or maybe about how to find a good place for the test to be used, so, you know, in Europe.
Yeah, so we're constantly, it's kind of, as I'm repeating myself in saying this, that we have a legal requirement, okay, here in Europe to improve the diagnostic always, okay? So we have to do a post-marketing performance evaluation, okay? And in this post-marketing performance evaluation, we actually utilize information coming from the clinics, okay, and coming from the clinical laboratories. So we're always constantly surveying which are the best peptides, which are the best manufacturing techniques in order to improve the test kit, so that we have less and less false positives and false negatives and less cross-reactivity. But not only that, so that, you know, the robustness, we're always looking at to see what emerging pathogen is coming up. So we're surveying, okay, what's happening with these with these pathogens. And it's interesting, there are some emerging ones, okay, and some that are still not so prevalent in the community, but we're keeping an eye out on these emerging pathogens. And if we see that there is, like, for example, Borrelia myomoti, the relapsing fever. Okay, so it is emerging. It's emerging on the other side of the world. It's emerging in Europe. Okay, we've had, I think, only one case here in Finland, but it's still emerging. It's emerging, and it's interesting, that one. Okay, so we're going to keep an eye on it. Okay, we're going to do some, analytical validation of certain peptides and proteins, and let's see if we include it into our test kit. But the phenomenon that we are seeing more intensely, and maybe this is a business secret, but you can see long COVID. I mean, you can see long COVID patients, right? Yeah. This reactivation of viruses. I mean, this is interesting. So let's, and also these patients, like, even Armin Schwarzbach is publishing the connection of autoimmunity and Lyme disease. I mean, that's really interesting for me too. So there's lots of areas that we can go into, but the key thing is that if a clinical laboratory is interested in actually diagnosing these complex diseases, okay, and complex patients because of their symptoms or the length of them being sick, okay, then this test kit can add value to their algorithms, okay, their diagnostic algorithms. And that's where we're looking at partnering with, is those clinical laboratories really wanting to tackle and handle these complex chronic patients, because we can find a solution for you and for them. And this test kit helps with these patients. So.
Wow, thank you. A lot of data, a lot of information. Do you have any final words for us, like a conclusion of our today's interview?
Yeah, I think through evidence, okay, we are going to be able to, change the tide in this diagnostics of chronic Lyme disease, but we have to come together and unite in this battle. Yes. Okay. Yeah, because only that way, through patients, clinicians, and scientists, okay, are we going to be able to actually change the tide. And that's the point. The tide can be changed, but only through unity will it change.
Yeah. Thank you for your work, and thank you, for all this information. They are very, very important for me as a doctor, for our patients. I really need to make the TickPlex more popular in Poland. That's my task at the moment.
Thanks.
Thank you for the time, Leona, and hope we will talk in the future maybe about some other ideas, or maybe if you're developing, if the test is changing as the population and the health is changing, maybe there will be new topics to discuss in the future. Thank you so much.
No, thank you too. Thank you for having me. Cheers.